Hello.
Hi guys, can you hear me? Not sure if you guys can hear me, but if you do, please let me know.
Yes, Dr. Ramadan, we can hear you.
Okay, sounds good.
Perfect. Let me just turn up the volume as much as I can, but we can definitely hear you for sure.
Awesome. I'm going to share my screen. So just so you know, guys, I was tasked to give 2 lectures that are going to be on 2 different days. It is not status epilepticus for today. It's actually going to be ICP management and cerebral edema. So I think the status epilepticus one is going to be sometime in April. Okay, so I should be sharing my screen now. All right, just let me know when to start. It's 3 minutes to 12, can give people a little bit more time.
Hi, Rev.
Yeah.
It's Jana. We'll just give everyone just a few more minutes, then I'll introduce you and we can get started. Is that okay?
Perfect.
All right. Thanks again.
Thank you.
our guest speaker for today. So today we have the privilege of hearing from Dr. Ramadan. Dr. Ramadan is a neurointensivist here. He's board certified in neurology as well as vascular neurology. Some of you, well, actually, some of the faculty may remember him from his training. He did a residency here, neurology residency here at Ford. And then he did a fellowship in neurocritical care at Johns Hopkins, as well as vascular neurology at University of Texas. And if that's not impressive enough, correct me if I'm wrong, Dr. Ramadan, but you speak 4 languages: English, Arabic, French, and Spanish.
That's correct. Yes, thank you,
Okay.
Jayna. This is
it sounded too good to be true, so I just wanted to verify. All right, so with no further ado, again, we very much appreciate you taking the time to speak with our program, and I'll just hand the mic over to you.
Awesome. Thank you, Jayna. This is a very generous presentation or introduction. So like I said, I was tasked to talk about ICP management, which is sort of a passion of, every neurointensivist and myself included. So this is what I'm going to be doing. Oops. All right. So a quick outline. We're going to be discussing the pathophysiology as it relates to intracranial pressure as well as intracranial hypertension, delving a little bit into the topic of cerebral autoregulation, which is tightly linked to intracranial pressure. Then we will go rather quickly on clinical course so that we can spend more time on management, and then discuss the overall sort of management, but more targeted to specific diseases that you may see in your practice and definitely in the medical ICU. Okay, so importantly, we always talk about a primary and a secondary injury. So primary injury can be an acute ischemic stroke, an acute traumatic brain injury, or spontaneous ICH, which essentially causes a dysfunction of neurons, as well as all the glial support and the connective pathways. That happens at the ictus, at the onset of the acute brain injury, and oftentimes, and for the most part, will lead to a cascade of events, whether at a macro or a microcellular level, leading to secondary injuries. Those injuries can be categorized in cerebral edema leading to elevated ICPs, but also cortical spreading depressions, which is sort of a more recent phenomenon that's been recognized. And it's a counter, essentially, a phenomenon, which is a positive phenomenon of having seizures and disturbed autoregulation. All of this sort of feeds into a supply-demand mismatch, which further exacerbates the primary injury. And at the center of this is the cerebral perfusion pressure compromise. And I'll talk more about CPP later. So just as references, normal intracranial pressure varies with age. In adults, typically between 4 to 15. If we want to be large, we can say up to 20. Definitely greater than 20 in adults is considered pathological, and may be affected by a number of factors, which can be physiological, such as obesity, which usually we will bring the ICP threshold a little bit above 20, up to 25. But then as in younger children, usually the ICP is normal ICP falls between 3 and 7, 1.5 to 6 for term infants, and even in newborns can even be subatmospheric. The sort of gold equation that's at the center of everything we do is cerebral perfusion pressure equals mean arterial pressure minus ICP. So to understand how ICP and CPP correlate, the Monroe Doctrine is the governing doctrine, and essentially this was established by 2 physicians, neurosurgeons actually, Kelly and Monroe, who essentially posited that the sum of volumes of 3 different compartments within the cranial vault, which are the brain matter, cerebral spinal fluid, as well as blood, is constant. And so if you have an increase in one, it should be accompanied by a decrease in the remaining 2, either one or both components. And the reason for this is because the brain, first of all, is enclosed in a very tight, non-expendable skull. 2, the parenchyma is nearly incompressible, and a continuous venous outflow has to happen in order to allow more arterial inflow. So as in any other organ, especially the lung or the heart, there is, even in the brain and inside the cranial vault, a compliance, and that compliance curve is parabolic. You can accommodate a certain amount of mass effect and increased volume up until a certain inflection point, where beyond that point, the intracranial pressure sort of rises exponentially. And we'll talk more about what that means. Essentially, the brain volumes can be defined as follows. The parenchyma takes about 80% of the volume inside the cranial vault, the CSF about 10%, and then arterial and venous blood share about 6 to 4% approximately. In a normal state, this is what it looks like. This is just a diagram sort of, giving you a quote unquote pie chart, of the different volumes and their proportions. When there starts to be a mass developing, whether this is blood or, for instance, brain tissue, such as in brain tumors, the brain can accommodate, like I said, up to a certain level while keeping the pressure, the intracranial pressure, normal. And usually this happens because the first 2 elements within the cranial vault, they sort of extrude in order to accommodate that growing mass, is the CSF and the venous blood. But once you reach a critical point where you cannot extrude any more CSF or venous blood, then different things happen. The arterial component becomes compromised because of vasoconstriction, which when critical can lead to ischemia followed by infarction and strokes. Once the arterial compartment has given out most of its compensation, then brain matter starts shifting. And this is obviously extremely worrisome, as you can imagine. ICPs can be measured either directly, and we have surrogate measurements that we'll talk a little bit more later. But the direct measurements usually happen with either an intraparenchymal bolt, which is inserted about 1 centimeter to 1.5 centimeter under the cortical surface, and the EVD, or the ventriculostomy, which essentially has a dual role of monitoring ICPs, but also allowing for CSF diversion and drainage. Other types of monitors can be inserted. We see them less commonly, such as, for instance, bolts placed in extraaxial compartments, the subarachnoid space, subdural, and epidural. Those usually give an ICP, sort of like a poor man ICP, with usually not the greatest waveforms, and they're mostly approximate values to the intraparenchymal ICP measures. More recently, we have developed an optic nerve sheath diameter measurement as a surrogate of ICP measurement. And this is particularly helpful in patients who cannot or who do not have any invasive monitor. So the concept of an EVD, essentially, it's usually can be placed at the bedside or in the OR. The neurosurgeons are trained to follow landmarks in order to place the EVD aiming at the third ventricle, and particularly more the foramen of Monroe. So they follow a certain landmark called a Cocker point. And essentially what it functions as a barometer. You set a certain level that you essentially zero at the level of the tragus, which in a patient who's at 30 degrees corresponds to the foramen of Monroe. EVDs come with a lot of complications. The most common is actually misplacement, which can happen in some series up to 45% of cases. And the more dreaded complication is infections. So ventricular associated infections, which can happen about 10% of the time. The most common pathogens are listed here. So skin flora with Staph aureus, epidermidis, Propionibacterium acnes is something that we commonly see in the neuro ICU. And then in cases of, VP shunt, we can see gram-negative bacilli, and in immunocompromised fungus infections become important. Different risk factors associated with those complications are obviously systemic infection, but also a breach in the skull, and a lack of tunneling. So if the EVD is not tunneled, the risk of infection increases. If there are multiple insertions, if there's violation of the system by a site leak, for instance, or frequent CSF sampling can also violate the system and expose it to infections. Very importantly, the duration of the EVD placement is something that we carefully consider. Usually, we like to keep EVDs for less than 10 days or 14 days if we want to stretch it. Beyond that point, the risk of infections increases dramatically. And for that reason, we actually impregnate now our catheters. They come impregnated with antibiotics, commonly rifampicin, for instance. This is why it gives that orange color to it, which is able to reduce the risk of infection by 7-fold. Another common complication is over drainage and intracranial hypotension that can potentially lead to subdural hematomas or hygromas. And obviously, you're breaching, the parenchyma, you can nick some vessels, resulting in hemorrhages. And that obviously that risk increases with your number of attempts and bleeding diastasis. So this is an example of an EVD placement gone wrong. You can see right here, the EVD tip, which probably is, this is a sagittal view, so it's you don't see the continuity, the entire EVD, but you see a very nice, probably an epidural hemorrhage here, associated with a tract hemorrhage and a pretty dramatic IVH. I can assure you this does not happen very frequently. This is a fairly catastrophic complication. So when we get, when we place the ICP, we look at a waveform. The waveform, usually in our monitor, our Philips monitor, appear here in purple. This is how we have it represented, in the neuro ICU. So we look at the waveform because it gives us actual information on the compliance status of, the inside the cranial vault. So normally there are three different elements or waves to that waveform. There's a P1, which is the percussion wave, which is your arterial sort of upstroke or pulse. The V2, which is called the tidal wave, is actually a measure of compliance. The reason for this is that when a patient has normal compliance, the P2 is lower than the P1, followed by a P3, which is the diachrotic notch corresponding to the aortic valve closure. But in a compromised compliance state, the P2 actually becomes greater than P1. Sometimes the two may actually even be sort of fused together. Even if the ICP is under 20 and normal, when you see a P2 higher than a P1, this is telling you something about the loss of compliance of the system. If you were to compress the waveform over time, you could also see the appearance of different waves called A, B, and C, well, the Lumbar waves by the person who discovered them. And essentially, the C wave is physiologic. It is oscillations that happened with cardiac and respiratory cycle. They're very frequent, so usually 4 to 10 per minute, and they may reach up to 20 millimeters of mercury, but these are completely benign physiologic waves. The lumbar A waves are the more dramatic and concerning. They're always pathological. When they happen, you have an elevation in the ICP that can reach up to 100 millimeters of mercury, and we've certainly seen this. Usually they're associated with ongoing or impending herniation, and they're thought to be related to the inadequate cerebral autoregulation that happens, and more blood flow being essentially the brain tries to respond by bringing more blood flow into it and raising further the ICP that can last up to 20 minutes. And in between those two types of waves come the lumbar B waves, which usually are pathologic, but they can be seen in more physiologic scenarios. They oscillate with less frequency than the C waves. They can reach up to 50 millimeters of mercury, and they usually indicate that you've reached the limit of your compliance without necessarily causing frank herniation. But now, why is intracranial hypertension so bad? Well, there are two main reasons for this. The first one is that the brain doesn't like when it changes morphology or conformation, and any white matter tract that is essentially deformed or sort of shifted can result in dysfunction, anatomical dysfunction. And there's obviously also the disturbed autoregulation. Either injuries can stretch the autoregulation to outside of the limits of compensation, or they can directly impair autoregulation. All of this culminates in a mismatch between supply and demand, causing a metabolic dysfunction. And so this is sort of a picture here that explains how the brain and the autonomic centers have an effect on resistance vessels, which are key in the cerebral autoregulation through its effect on the cardiovascular system, increasing peripheral resistance, but also cardiac output, leading to an increase in the CPP. Those resistance vessels are under also direct effect of the autonomic centers within the brainstem, and can be modulated or affected by CO2 concentration, brain metabolism, also seizures. And this is how essentially the brain sort of regulates how much blood goes into it, because more blood means more elevated ICPs. And this is the classic autoregulation curve that we see. The blue line is actually a normal autoregulation curve. So over a large or a wide, blood pressure range from 50 to about 150 of MAPS, and surrogate to that would be cerebral cerebral perfusion pressure could also be on the x-axis. But over this wide range of pressures, the blood flow remains fairly constant, and this is because of those resistance vessels that change in caliber. So when the blood pressure falls, those vessels dilate in order to bring more, or optimize, perfusion and increase perfusion. And conversely, when the blood pressure increases and the brain sees a rise in that blood pressure, those vessels constrict, sorry. So vasodilate and vasoconstrict here. But at a certain point, even in a normal non-injured brain, once you reach the limits of compensation, you lose the autoregulation, and those vessels who were maximally constricted at the upper limit of autoregulation, essentially the vascular tone collapses, and they, under the effect of the blood pressure, will maximally dilate, and this leads to breakdown in the blood-brain barrier, vasogenic edema, and can even lead to, in the more dramatic scenario, can lead to hemorrhages, as depicted here on the CT. The other end of the spectrum, when the blood pressure falls below a certain critical point, the vessels are not able to maximally dilate anymore, and there's essentially a collapse of the arterial system, leading to a very perfusion-dependent system that essentially results in hypoxia, ischemia, and infarction. That curve is shifted to the right in chronic hypertensive patients, and this is the reason why you have to be careful with controlling blood pressures and rapidly dropping the blood pressure in those patients, because they can essentially reach the lower end of their autoregulation, start developing signs of ischemia at higher blood pressures compared to normal tensive patients. And in hypercapnic patients, essentially hypercapnia lowers the pH, and cerebral pH, when it goes low, causes vasodilation. So the curve is actually shifted upward. And in the case of severe brain injury, whether it's focal or more diffuse, you lose autoregulation. Essentially, blood pressure or cerebral blood flow start varying linearly with the blood pressure. So very sort of important concept to keep in mind. The cerebral blood flow thresholds are as follows. So, normal is 50 and above. When you start going down to 25, your EEG starts showing slowing. When you drop, your cerebral blood flow further in between the range of 5 and 15, you're essentially developing ischemia and a penumbra, which under 5 can lead to neuronal death and essentially a flat EEG line or isoelectric EEG. Cerebral blood flow, like I mentioned, is also varies as a function of PaO2 and PaCO2. So as you increase PaCO2, your vessels vasodilate and their cerebral blood flow increases. As you decrease the PaO2 in hypoxemic conditions, the vessels do the same. They vasodilate in order to optimize perfusion. But ICP is not the whole story. I mentioned, the cerebral autoregulation can now also be somewhat measured, and we have different tools to do that. All of this is part of the multimodality neuromonitoring that is becoming, that's gaining in popularity and sort of allowing us to tap into the black box that's the brain. So we have different ways of monitoring for cerebral autoregulation via PRX or near infrared spectroscopy. We can directly now measure brain tissue oxygenation. We actually have that capability here at Henry Ford. We can measure function via EEG and quantitative EEG, and we can also measure the metabolic rate of the brain using microdialysis, so essentially sampling via a little catheter, CSF, and looking for glucose, pyruvate lactate, and glutamate, and making a lactate to or calculating a lactate to pyruvate ratio. I'm not going to go into this, but just so you know that ICP is not the whole story. We have a lot of different ways now to look at cerebral autoregulation, cerebral metabolic rate, which are definite important factors in outcomes after brain injury. So delving into the pathophysiology, we have two different sources for brain water. There is cellular respiration that produces essentially intracellular water. And then there's water that comes from outside of the brain through the circulation and through the blood-brain barrier. The concept of diffusion is very important and applies to brain injuries, and we'll talk about this and its repercussion in on management of cerebral edema. But essentially, water moves down an osmotic gradient to equilibrate the concentration, and there's a second way of transport of water across membranes. It's via bulk flow, which essentially moves down a pressure gradient. But the brain protects itself via tight junctions from that bulk flow. It's usually facilitated by other types of transporters or fenestrations and gap junctions. Not every molecule can, or different solutes have different reflection coefficient, which is something that we look at when we are trying to assess the efficacy of a molecule to essentially draw water across a membrane. So you can see here that normal saline, sodium chloride has the highest coefficient, 1, but mannitol has a fraction of it, so 0.9, not as good as sodium chloride in drawing water. And urea is much lower, as about half, 0.5 to 0.6. When we talk about edema, there are different types of edemas. There's an early cytotoxic edema that usually happens within minutes and can last for hours to days. This is essentially a breakdown of that metabolic or metabolism within the cell, resulting in a dysfunction of the sodium potassium ATPase pumps. So water actually gets trapped within the cells, and there's no net gain in water content of the brain at that point. It's all transcellular shifts of water that just accumulate within cells like neurons and glia and lead to that cytotoxic edema. The best correlate that we have on an MRI are the ADC and the DWI sequences. This is hyperintense DWI in a patient with an acute large MCA stroke that appear all bright, hyperintense here. And then following the cytotoxic edema comes vasogenic edema, which happens a little bit later, usually starts within hours and peaks at a few days, can even last for weeks to months, depending on the underlying pathology. But what happens here is that there's an actual breakdown in the blood-brain barrier. Those tight junctions are very leaky, and essentially the water that comes from circulation, extravasates into the extracellular fluid compartment and results in a net increase in brain water content. The best way to actually assess for vasogenic edema on an MRI is the T2 flare sequences, again, hyperintense here. So the two edemas, obviously, for most brain injuries coexist. It's just a matter of different pathophysiologies and timing. This is an extreme case of an MCA stroke that was left untreated, resulting in a cytotoxic edema at first within the first 24 hours, leading to more brain water accumulation and vasogenic edema, essentially causing all sorts of different herniations. again, more of the same. This is a busy slide, but essentially summarizing the differences between cytotoxic and vasogenic edema. There are two other types of edemas, which are the transependymal or interstitial edema, when there's an obstruction of the ventricular system, essentially forcing CSF outside of the ventricles into the brain parenchyma. And an osmotic edema is also something that's commonly seen in the MICU, for instance, where there's essentially it's sort of close to vasogenic edema, but instead of an increased vascular permeability, it is essentially a change in the osmotic or osmolality of the plasma respective to the brain parenchyma, which essentially leads to water moving down the osmotic gradient into the brain parenchyma, and that can be seen in conditions such as hypoglycemia that's treated very rapidly, or hyperglycemia, sorry, that's treated very rapidly with insulin, or for instance in the classic dialysis disequilibrium syndrome that I'll be talking about a little bit more. Increased intracranial pressures or hypertensive or intracranial crisis usually presents with an early change in level of consciousness. You may see papilledema on a fundoscope. Very early on, you can actually start seeing palsies, bilateral palsies of your cranial nerve 6. And this is sort of like a subtle exam finding that usually tells you, it's a false localizing sign that tells you that the intracranial pressure may be elevated. You may also, start developing sunset eyes, unable to, look up. And the classic, Cushing reflex or Cushing response with an increase in the blood pressure, bradycardia, and a change in the respiratory pattern. Pupillary changes tend to occur later, and this is with usually, frank herniation, uncal herniation, as well as focal deficits such as sensory or motor symptoms. These are, different herniation syndromes, the trans or subfalcine herniation right here, descending central transtentorial herniation, an ascending transtentorial herniation, external herniation of brain through a brain defect or a skull defect, the very dreaded uncal herniation compressing the midbrain, the cerebral peduncle, as well as the cranial nerve 3 nucleus, and a tonsillar herniation of the cerebellar tonsils through the foramen magnum. I'm not going to go into the different symptoms. It's for you to peruse later. But what I find interesting is that we commonly measure a midline shift, and when we measure it, oftentimes we measure it at the level of the septum pellucidum, but the actual correlation between level of consciousness and midline shift happens at the pineal gland. And the reason for this is that the pineal gland is not some important structure for consciousness, but it's located in the midline, very close to centers that are part of the activating reticular system. And therefore, this is why we use the pineal gland that's often calcified and can be readily seen on the CAT scan as a landmark. And there was a pretty landmark paper that was published in the New England Journal of Medicine that correlated the displacement, the horizontal displacement of the pineal body with the actual level of consciousness. You can see that once you hit 8 millimeters or more, patients were usually in a state of coma. So now in terms of management, as I said, the different compartments of the brain become affected at different time depending on the degree of mass effect. And we target essentially every single one of those compartments in our management of elevated ICPs. So this is sort of a summary slide, and I'll be discussing all of these in detail. First, step in your management is obviously minding your ABCs, right? Because if there's no blood flow to the brain, there's no brain function. And this is the reason why airway, securing it and oxygenating the brain is extremely important, but also securing your airway, which allows you to hyperventilate and decrease ICP via hyperventilation. And obviously your circulation, you're trying to maintain a CPP in the face of very elevated ICPs. So imaging is obviously never the first step in management. You need to stabilize your patient first, even when you suspect that there's a clinical deterioration due to an elevated ICP. Start the first tier of management even before you send a patient to the CAT scan. And the reason for this is because those patients frequently are laid flat. And by laying flat, you're impeding your venous return, which is a very detrimental and very easy to fix factor of that can elevate your ICPs. The ENLS, or the Neurocritical Care Society, came up. I think most of you now are familiar with the Emergency Neurologic Life Support, or ENLS, that put it very nicely in an algorithm or a diagram. What are the different tiers of management when it comes to intracranial hypertension? So as I mentioned, tier 0, so the first things that you're going to want to do is optimize your cerebral venous outflow. You elevate the head of the bed 30 to 45 degrees. You try to keep your patient's head in the neutral position. And this is extremely important because a kinked jugular vein, either as a result of tilting, head tilting, but also, the result of compression over the jugulars by a C collar or, the ET tube ties can dramatically increase your intracranial pressure. And you can do this at the bedside. And if you have an ICP monitor, see how, the ICP varies by just compressing 1 or 2 jugulars. So you want to relieve any compression over the neck. You also want to try to avoid inserting subclavian or IJ catheters. Because first of all, that will usually require putting a patient flat, and it can also interfere with venous outflow if they were to develop a thrombus. So in crash situations, when a patient is actively herniating or there's an elevated, ICP crisis, a femoral central venous catheter is preferable. Then you want to, obviously, after a patient has been intubated, you want to provide some light sedation and analgesia, because agitation and pain can raise, the ICPs. You also want to treat nausea, which can in itself raise ICPs, but also contribute to hyponatremia or cause hyponatremia via SIADH. And obviously you want to remain very cautious when you're sedating a patient whose airway is not secured. Once you've done those standard measures, the tier 0, you move on to tier 1, which a lot of times all of these things are happening at the same time, right? So if you've secured an airway, even if the patient doesn't have a secured airway and all you have is a bag valve, you can start bagging the patient to hyperventilate them. And that hyperventilation brings the CO2 down. You want to, in an acute crisis, you want to target a PaCO2 of 25 to 30 or 30 to 35 if you have an end-tidal CO2. But you want to do this for a limited period of time, and you certainly do not want to drive the CO2 lower than 20, because if you do, then the vessels constrict to a critical extent, and you can actually induce strokes just by doing that. Once the patient's, ICPs are outside of that crisis, but still are experiencing, elevated ICPs, then you can relax your CO2 goals to 30 to 35. And if you've taken a patient to a decompressive, crani, for instance, then you can more fully relax, your CO2 goals. So very important to keep in mind, where you're at in terms of timeline in the management of those patients. Along with hyperventilation, we use osmotherapy that comes usually, most commonly in two flavors, hypertonics or mannitol. The point obviously is to create an osmotic gradient so you can shift water away from the brain and into the intravascular compartment. But osmotherapy also improves the rheology of the blood. So it improves the deformability of RBCs, leading to lower viscosity. And it also dehydrates the cerebral endothelium, which increases the lumen diameter and improves, vascular flow. It's very important to also understand that the brain tries to compensate for the increased osmolality that it sees by producing osmoles, organic osmoles, and essentially extruding those osmoles so that the brain doesn't, not extruding, but producing those osmoles and maintaining them inside the intracellular compartment so that the cells do not shrink too much. So it's a sort of like a compensatory or a defensive mechanism, which becomes very important as you wean, your osmotherapy because of this lag in time and in the production of those osmoles. And if you were to wean too quickly your hypertonics or your mannitol, just the presence of those intracellular osmoles can lead to a rebound cerebral edema. So we're usually we usually wean as slowly as we can, and it also depends on how long we actually kept the patient on hypertonics or mannitol. So mannitol can be usually given as a bolus. We do not like to use it as a continuous infusion because of the risk of rebound cerebral edema. We are also careful with how much we give because of the side effect of acute kidney injury. So we usually avoid going above an osmolality of 320. And we usually also measure the osmolar gap, and we try to stay under an osmolar gap of 20. So when we use mannitol, we use it, like I said, as a bolus. The effective dosing is 1 to 2 grams per kilo. And we can, and this is when really a patient is actively, herniating. But then when you want to control the ICPs to less than 20 or less than 25, you can use intermittent doses at a dose of 0.25 or 0.5 gram per kilo every 4 to 6 hours. As you do this, always remember to check your osmolality as frequently as you're administering mannitol. The big advantage of mannitol is, first of all, it's readily available, and second, it can be given through a peripheral IV without any problem. Big side effects that we are always on the lookout for are obviously renal failure. We try not to give that medication in a patient who's, an advanced kidney injury, but also hypovolemia and hypotension. And that's the reason why we usually will follow the mannitol infusion with a bolus of either normal saline or hypertonic saline in order to not precipitate hypotension that can negate what we're trying to do and reduce the cerebral perfusion pressure. Hypertonic saline comes in different flavors, all the way from 1.5% of NaCl to 23.4, which we usually refer to as a sodium bullet or a sodium bomb in different places. There's up until, recently, I mean, it's been several years now that there's more active research that actually shows that 3%, even a 23.4% in a more recent paper, that actually came out of University of Michigan, shows that it's actually safe to give those high concentrations of sodium chloride through a peripheral IV. Still, in our facility, we require a central venous catheter for infusion of 3% and above. Okay, so 2% we can still do it through a peripheral IV. I'm hoping that we're going to change, the way we actually do things here, just based on the more recent evidence. Your goal is usually to raise the serum sodium by about 10 milliequivalents. You can usually do that in a 70 kilo person by infusing a bolus of 500 mLs of 3% or 60 mLs of 23.4. But it's also important to realize that usually most neurological symptoms associated with hyponatremia, if the patient were hyponatremic, here we're talking about mostly raising the sodium in this setting of a cerebral edema. But if a patient who comes in with hyponatremia and you're trying to reverse their encephalopathy or seizures, usually a rise by 5 to 6 or 7 is enough in reversing those manifestations. It's usually preferable to use over mannitol in hypovolemic patients, but it can be complicated by thrombophlebitis, flash pulmonary edema, coagulopathy, and very importantly, hyperchloremic non-anion gap metabolic acidosis. And this is the reason why we have available, buffered solution that are 50% concentrated or 50% chloride and 50% acetate in order to mitigate, the chloremic load. Then steroids can be used. There are very few scenarios where steroids are actually beneficial in cerebral edema. It's in tumors and meningitis. And I'll talk actually a little bit more about this as we discuss, the different clinical scenarios. But usually any steroids can be given. Dexamethasone or Decadron is the one that's been, used for a very long time, past 40 years. It's readily available. It's got a long half-life, as mentioned here, 36 to 54 hours, and it's a 1-to-1 conversion from PO to IV. Again, within your tier 1, if the patient has the room to put an EVD catheter inside their ventricles and essentially not just use it as a monitor, but also as a for its therapeutic end, then you should place it, especially if a patient comes in with hydrocephalus. If it's obstructive hydrocephalus, you always want to use an EVD and not a lumbar drain, because you don't want to create that pressure differential and precipitate herniation. But if a patient has communicating hydro, this is where a lumbar drain is a possibility. Initially, we set the level at 5 to 15. So any ICPs, above 15 will drain, CSF, or will cause, CSF to drain through the system. And our goal drainage, so that we don't overdrain, is usually 5 to 15 cc's an hour. We can talk about, EVD wean, whether we do it rapidly or intermittently. It's probably more a conversation for the neuro ICU. I'll skip that for now. And then if you're still, experiencing a herniation, you haven't been able to reverse the symptoms, or the ICP is still, tremendously elevated, you move on to tier 2, where you're actually pushing your sodium goal even higher, up to 160. Above that point, above 160, it's usually not, first of all, beneficial or recommended, because it's associated with, adverse effects. So the most we will go up is to 160. And then comes, your heavier sedation and analgesia. The goal is to actually lower your metabolic rate, your cerebral metabolic rate and consumption of oxygen, so that you're decreasing cerebral blood flow and by that token, also decreasing ICPs. You also want to make sure that the patient is not fighting the vent and there's no vent asynchrony. And the preferred, analgesic and sedative that we use is fentanyl and propofol. These two actually have a direct effect on lowering the ICPs. You want to target, initially light sedation, but you may have to go down to a RASS of -4, -5, if the ICP is refractory. And then we move on to the refractory ICPs. Those patients will require more drastic, interventions, and unfortunately, those interventions have not been shown to improve outcomes. And these are neuromuscular paralysis to prevent, any movement, any coughing or shivering. Obviously, the side effects are that you're losing your neurological exam, and if you use it for a prolonged period of time, especially in patients with sepsis or alongside, steroids, you can induce a pretty profound, myopathy. And then hypothermia. So hypothermia has only been shown to be beneficial in post-anoxic injuries, but sometimes in refractory ICPs we will use it. It is, like I said, effective in bringing the ICP down, but it has not translated into better outcomes. Hyperthermia is a pretty potent vasodilator, as this is what we're trying to prevent. So avoidance of hyperthermia, whether or not you're cooling your patient, is crucial. And then shivering is a major complication that in itself can increase ICPs, and you want to be able to manage and counter as much as possible. The side effects of deep hypothermia, you all know them, and they're listed here. And then finally, we use barbiturate coma in extremely refractory cases. Usually those patients, have either undergone surgery and they're still extremely refractory, or they're not, responding to any medical management. Essentially what you're trying to do is you're trying to reduce, again, your cerebral metabolic rate. We usually use as an infusion penobarb because it's got a shorter half-life, 15 to 50 hours compared to phenobarb, which is double that. And we always bolus and follow it with an infusion. We always have a patient monitored on the long term, because what we're trying to achieve is burst suppression. So it's a specific pattern on EEG, which is we don't want to overshoot it and make the patient completely suppressed with an isoelectric EEG. We want to achieve this lesser degree, but still pretty suppressed, called burst suppression. Typical side effects of barbiturates include hypotension, electrolyte disturbances, especially hypokalemia, but also immune suppression. Those patients become extremely susceptible to sepsis, and they'll drop their blood pressure pretty readily because it's a cardio, essentially decreases myocardial activity and vasodilates, and you will have to replace fluids and a lot of times put patients on vasopressors. And then surgical intervention. So obviously, depending on the etiology, you will, perform surgery or not, and different types of surgeries. So resect tumors, drain abscesses, evacuate hematoma, and specifically when it's an extraaxial hematoma, you have to evacuate it. When it's an intraparenchymal hematoma, the jury is out in terms of the efficacy of doing open versus minimally invasive. It's a whole topic on its own. I won't go into this. Sometimes, especially when it's a focal injury and you just want to open the cranial vault in order to relieve the pressure, you perform a decompressive craniectomy. That can be associated with removing some dead, brain tissue via a total or partial lobectomy. We talked about diverting CSF, and interestingly, also sometimes in cases of abdominal hypertension or abdominal compartment syndrome with transmitted, pressures to the brain, you may actually have to take a patient to a laparotomy, and I've actually seen a couple of patients like this. So I know I don't have much time left, but I'm almost done. I wanted to discuss, specific diseases and how we manage, cerebral edema in them. So tumors, steroids, like I mentioned, has only been shown so far to be beneficial in treating bacterial meningitis and tumoral edema. There was, in the TBI literature, it was actually associated with worse outcomes. That's in the CRASH trial with increased mortality. And in stroke, it was actually not found to be beneficial with odds ratio of 0.87. And I already mentioned, steroids. You can also obviously use hypertonics as a bridge until you relieve, the pressure, surgically. For intracerebral hemorrhage, we don't actually have the greatest therapeutic interventions for that. Decompression is a plus or minus when it's intraparenchymal. Like I mentioned, there was actually no benefit found, whether it's on mortality or functional outcome in the 2-stitch trials that were done. And now we are actually trialing more minimally invasive techniques, either by inserting a catheter right into the intraparenchymal hemorrhage and instilling TPA and removing the clot that way. So this is the basis of the MISTY trial, or doing even less invasive surgeries by removing a clot, trying to navigate around the sulci so that you're not essentially disrupting white matter tracts. And this is the ENRICH trial. There's also endoscopy that's actually now being trialed as well, which seems to be actually very promising. But there's no role to steroids, and your mainstay treatment is going to be blood pressure control, prevention of expansion by reversing any coagulopathy, and also as a bridge, until that wave of cerebral edema remits, you can also use and should use hypertonics. It's really the only real specific treatment that we have for that. For ischemic strokes now, especially when it's associated with malignant edema. So malignant meaning that, that it's actually causing symptoms and herniation. In patients that are younger than 60 years of age, there's actually extremely good and solid data to suggest that early decompression within 48 hours associated with the lobectomy or not actually improves survival and functional outcome. There are 3 different trials from Europe that were done. That's now 20 years old. Unfortunately, there was that benefit was not extended to patients that were older than 60 years old. So usually those patients may survive, but they may be kept in a very debilitated state. So we don't necessarily offer right off the bat, decompressive hemicraniectomy to elderly patients, unless we've, discussed with families expectations. We can use hypertonics, but it's only used as a bridge. If a patient needs surgery, they need surgery, and we usually don't want to wait until they blow a pupil to take them to surgery. There's a recent retrospective study, that's probably the largest study, that actually showed that yes, hypertonics can improve, midline shift, but it's got no effect on outcomes or reducing the need for surgery. Steroids have been shown to be either, depending on the study, either deleterious or have no effect. And currently, we're actually studying hypothermia in the acute or ultra acute, stages. But the data so far doesn't suggest, any significant role of hypothermia. Anoxic brain injury, definitely, something that you guys come across all the time. The only real treatment that has been shown to improve outcome is targeted, temperature management. And this has also been sort of also put in question, with the recent TTM2, whether it's avoidance of fever versus actual, mild hypothermia. And that benefit has been extended to, non-shockable rhythms and, in-hospital cardiac arrest. There's absolutely, unfortunately, no role for hypertonics or even bifrontal decompression. There's no proven benefit, and definitely not for steroids either. So our hands are very tied when it comes to the treatment of an Oxybrain injury. For hepatic encephalopathy, we want to be very aggressive with lowering our ammonia. We are even more so aggressive now by initiating renal replacement therapy as early as possible, in conjunction with using lactulose and rifaximin. Hypertonics, again, no real benefit. And the reason for this is that when you use hypertonics, you're trying to shrink the good brain, the healthy brain, the one that doesn't really have a very disturbed, blood-brain barrier. And when the process is diffuse, like in anoxic brain injury or hepatic encephalopathy, unfortunately, you don't see that much of a benefit. And then hypothermia, in a paper, was actually shown to improve outcomes, but only in patients who had their hepatic or fulminant hepatic failure as a result of acetaminophen, and that were usually younger than 25 years. And then finally, dialysis disequilibrium syndrome. I briefly mentioned it before. But essentially, what happens with first timers, who just start undergoing, HD, is that you're reducing very quickly, very rapidly, a chronically elevated, BUN, where those and causing this major drop in your osmolality, because BUN still has a pretty important contribution to serum osmolality, and as a result, water essentially follows your osmotic gradient and cause the neurons and the glial cells to swell. So what we do in order to counter, and prevent, the formation of that disorder is to limit the first, dialysis session to about 2 to 2.5 hours, limiting the blood flow. We may actually increase our sodium bath in order to counter, that drop in the in the osmolality by raising the sodium component of it. Sometimes may even use, mannitol. And obviously in patients who are at very high risk for this dialysis disequilibrium syndrome, especially those patients with intracranial pathology, we usually want to do a more continuous renal replacement therapy, whether it's SLED or other modalities. And this is it. Thank you for your attention, and I'll be happy to take any questions.
Thank you. I'm just going to open up the floor for any questions. If you have a couple of minutes, Red.
Oh, I am. I do.
You do? Okay. Any questions? Yeah.
Sorry, if there's a question being asked, I can't hear anything. So Jaina, you may have to repeat that question.
Yep. I can repeat it for you.
Okay, thank you.
We're just finishing up with the question, and then I'll let you know. Yep. So the question is surrounding a patient population we see pretty often in the MICU. So the post-cardiac arrest patients, where we obtain CT imaging, usually a non-con, and it does show diffuse cerebral edema. In those types of patients where you have imaging of edema, as well as many of them, their mental status is altered, depressed. Is there any, and they're on targeted temperature management, is there any indication for hyperosmotic medications such as hypertonic or mannitol in that population?
No. Unfortunately, first of all, there is theoretically, when you just think about it theoretically, just because of the global, diffuse disruption, and pathology, you're essentially, like I said, we use osmotherapy, whether it's hypertonics or mannitol, to essentially shrink, the brain water content of healthy tissue to accommodate, for the expansion of the diseased tissue. But in this case, the disturbance, or the injury being so diffuse, it has very little benefit. You may see a very transient benefit sometimes. A lot of times, we can't even measure it, just because those patients are not even candidates, for ICP monitoring. But you may see a very transient effect. The problem is that and that obviously depends, on the severity of the injury. But this is a relentless process that we cannot stop, and we cannot use hypertonics as a bridge. And like I said, hypertonics have a very limited benefit on the ICP reduction per se, so no, unfortunately, and there's a lot of data actually backing up, the absence of real benefit in that patient population.
Thank you. Any other questions? I know we're keeping you after, but I had one. So you mentioned the increased ICP secondary to hyperammonemia, and how we're being more aggressive with renal replacement therapy, lactulose, and rifaximin. In my experience, though I've been told we don't go by an absolute ammonia number, that has often been a reason to either say push forward with renal replacement therapy versus not. Is there any correlation that you've seen in literature between the ammonia level and needing these more aggressive managements to decrease ammonia and help the ICP, or is it mostly based on your encephalopathy scoring?
No, so the encephalopathy score, if you use, the West Haven, criteria, actually does indeed correlate with the degree of hyperammonemia. The number that you'll see in the literature is 200. So above 200, you can be almost certain that patients are going to, especially when it came on acutely, that patients are going to be experiencing cerebral edema. And so we usually try to definitely bring the ammonia level less than 200, and more anecdotally, and more sort of practically, we usually try to target an ammonia of less than 100. But yes, there is a correlation between your ammonia level and your cerebral edema, especially when it's above 200.
All right, thank you very much, Dr. Ramadan. That was an excellent lecture. Included a lot of helpful board tips as well, so thank you.
Okay, you're welcome. Take care, guys. Have a good day.
Bye, Red. Thanks.
Bye.